First of all, thank you very much. It's an honor for me to help Raja and Ben in this ACNS webinar. We know that they are very consistent over the years to provide education through all over the world through this webinar. In this topic, I would like to introduce Dr. Zong Dong. So as we know that the endoscope is a highly valued visualization tool in neurosurgery. And I think what he will lecture us after this is very important. It's how to application of rigid variable view endoscope in individualized treatment of IAC during surgery of vestibular schwannoma. I know that this is a big problem still for us, especially the one that's only using the microscope without the enhancement of endoscope to visualize this very small and specific area. I really hope that from this lecture, we can gain a lot of messages and also the one that can apply to our daily practice. For Professor Zong Dong, please, the time is yours if you want to start.
Thank you, Dr. Sophie. Thank you. Good evening, everyone. I will share my PPT. Good evening, everyone. It's nice to meet you. I'm Zong Dong. I come from the Department of Neurosurgery, the first affiliated hospital of Chongqing Medical University. Today, we will Dr. Wu Yue, Dr. Shi Shuang is my team member. Today, we will talk about application of rigid variable view endoscope in individualized surgical management in the auditory canal during acoustic surgery. Acoustic neuroma surgery has been developed over 100 years. Our target is to resect the tumor as much as possible based on the preservation of function of facial and cochlear nerve. There are many hotspots about acoustic neuroma surgery. Today, I will focus on the management of IAC via retrosigmoid approach. The management strategy of IAC via retrosigmoid approach is divided to one, not to draw. It's very rare. Two, don't draw, only scrape. Three, draw open the posterior wall of IAC. Four, draw open the superior posterior wall of IAC. Five, microscopic, endoscopic combined surgery. We recommended the management of IAC with the microscopic, endoscopic combined surgery under the three following conditions. One, there is a high hypogasification of posterior wall of IAC, and there is a high jugular bone. Three, the tumor is almost complete filling of the IAC. Case 1, left acoustic neuroma, cause 2. A 45-year-old male suffering from dizziness and left air tinnitus for 2 weeks. Physical examination suggests a slight hearing decrease in left air. Preoperative MRT2 image show most of the acoustic neuroma grow into the internal auditory canal. There was just a little CSF signal at the natural edge of the tumor inside IAC. Enhanced MRI image shows the tumor was lobulated. CT bone window images show the left IAC has expanded. CTV show there was no high jugular bone on the left side. Preoperative hearing test is class A. Reasons for the procedure. 1. Surgical resection allows immediately cranial nerves decompression. 2. Radical resection allows for the protection of facial and cochlear nerve function and would yield the best long-term control of the acoustic neuroma. 3. Under the rigid variable view endoscope, The retrosigmoid transmental approach provides radical resection of the residual acoustic neuroma in the fundus of the IAC under direct vision. Benefits of the procedure include safe operation under direct vision, radical resection of the tumor, protection of facial and cochlear nerve functions, long-term control of the tumor. Its potential risk include cranial nerve injuries, hearing loss, intracranial infections. Plan B include observation and radiotherapy. The reason why they were not chosen: the patient has symptoms of tinnitus, which affect his quality of life. The patient is young. If the tumor grows after radiotherapy, the difficulty of surgery will increase. We take the park bench position and the straight insertion behind the lift air. The critical equipment include a digital variable view endoscope, high-speed drive system, intraoperative neurophysiological monitor. Key surgical steps. 1. Sharp dissection of the arachnoid interface of tumor in the cerebropotin system. Partially grind open the posterior wall of IAC. Remove tumor in the cerebropotin system inside the IAC and at the pores of IAC under microscope. Under microscope, use the novel 3-piece set internal ordinal canal dissector to scrape residual tumors in IAC. 5. Under the digital variable view endoscope, adjust the angle from 15 degree to 90 degree, step by step, so as to see the fundus of IAC. Then scrape off the residual tumor in the fundus of IAC under direct vision. 6. Effective neurophysiological monitor throughout the operation is critical. 7. Seal the posterior wall of IAC tightly. That has been grind open with bone wax and muscle particles. This is our microscope endoscope combined training center. Let's move to the training in anatomy knob, right retrosigmoid approach under the digital variable view endoscope at 90 degree. Neuroanatomy is the foundation of neurosurgery. Neuroanatomy training is the cornerstone of neurosurgeon training. To do a good job, one must first sharpen his tools. We operate with our 3-piece set of IAC dissector. The head of these dissectors have different shape, angle, and cutting edge. This is the number 1 dissector. And this is number 2 dissector. We can see the dissector can easily reach the bottom of the IAC. Even the posterior wall of the IAC has not been ground open yet. And this is number 3 dissector. It's a scraper. We can see the scraper can also easily reach the bottom of IAC. The rigid variable view endoscope have 5 adjustable angles from 15 degree to 90 degree. The endoscope holder was used to hold the endoscope during operation, so we can freely use our microsurgical instrument with 2 hands. We can see the bottom of IAC under the retro variable view endoscope. The problem remains how to perform surgical operation in the narrow IAC through the variable view endoscope under direct vision. The key is appropriate microsurgical instrument. These are the microsurgical instruments we have used years ago for the management of tumor inside the IAC. How to improve the medical instruments best be used under variable view endoscope. Number one detector. This is number one detector. It's spade shape. The smallest of the three-piece set of IAC detector with cotton edge facing two sides and the front. It used to separate the loose adhesion between the tumor and the facial and cochlear nerve near the opening of the IAC. This is the number two detector. It's hollow. It's used to separate the loose adhesion between the tumor and the facial and cochlear nerve near the bottom of IAC. Meanwhile, to suck the tumor posteriorly with suction. This is number three detector. It's a scraper. It's spade-shaped, hollow, with a round front end and with a blade face upward. It's used to scrape the tumor-carrying nerve sharply against the bottom of the IAC towards the posterior wall and scrape the residual tumor at the bottom of IAC towards the posterior wall. Let's move to the training in anatomy knob again. Right retrosigmoid approach under the rectal variable view endoscope at 90 degrees. Then the posterior wall of IAC has partially grand open. Microscopic and neuroendoscopic have their respective advantage and can complement each other. Young neurosurgeons should master these two techniques. We can freely operate with two hands. We can freely use the suction and the detector at the bottom of the IAC. We can see the exposure is more extensively at the bottom of IAC. We can easily use the scraper to scrape the posterior wall of IAC behind the superior vestibular nerve and inferior vestibular nerve. Pictures taken from the training in the anatomy knob. From picture 2 to picture 4, the posterior wall of IAC has partially grand open. Picture 2, from the rear view, we can see the SVN and IVN are in the rear of IAC. Picture 3 removes the SVN and the IVN. We can see the facial and cochlear nerve are in the front of the IAC. As we know, the facial and the cochlear nerve is in the front of IVN or SVN, which may carry acoustic neuroma. So it is safe to scrape backward sharply. The difference between variable view endoscope and the traditional endoscope are mainly shown in two aspects. New spatial relationship between the four nerves in the IAC under multi-angle vision. How can we resect the residual tumors with more appropriate microsurgical instruments? We consider the treatment strategy to deal with IAC must be individualized, and microscopic endoscopic combined surgery is one of the best ways. We also considered operate under the variable view endoscope. Use appropriate microsurgical instrument is critical. to scrape residual tumors in IAC backward under the digital variable view endoscope is safe and effective. Before watching the surgical video, I would like to say that we take the park bench position and the patient is lying on his right side, and we talk straight incision behind the left ear. So the right side direction of the picture is toward his head, and the left side direction of the picture is toward his feet. Now, let's move to the surgical video. Firstly, we dissected the arachnoid interface of tumor in the cerebral protein angle sharply. We can see the petrous vein. The facial and cochlear nerve are located below the acoustic neuroma. We grind open the posterior wall of IAC in C shape and take care of the door in the IAC to protect the structures in IAC. In order to avoid damaging the functioning structure in petrous bone, such as semicircular canal, the drawing length of IAC via the sigmoid transmental approach is limited. We blunt dissected the adhesion between tumor and nerve in CPA. Once again, we can see the facial and cochlear nerves located below the anterior part of the IAC. Then we remove tumors that adhere with the facial and cochlear nerve tightly in the front of the hollows of IAC. Then remove tumors in the IAC under microscope. We suck the tumor with suction backward and pull the tumor towards the porous of IAC and separate the tumor from the facial and cochlear nerve. At the same time, we strive to protect the facial and the cochlear nerves. Bipolar stimulator was used to confer the facial nerve during the operation. We use 3-piece set of IAC dissector to separate and scrape the residual tumor in IAC. Its head has different shape, angle, and cutting edge. This is a lumbar 3 dissector. It's a scraper. It's used to scrape the tumor-carrying nerve sharply towards the posterior wall and to remove the residual tumor at the bottom of IAC. Under the digital variable view endoscope, adjusted the angle from 15 degree to 90 degree, step by step, so as to see the foundations of IAC. we can directly see the residual tumor and related nerves at the fountains of IAC. Three-piece set of IAC detector combined with variable view endoscope enable us scrape residual tumor out from the fountains of IAC to achieve total resection, avoiding the damage caused by blinding scrape. The operation at the fountains of IAC is relatively simple, which is to scrape towards its posterior wall. The tumor carrying nerve of acoustic neuroma is located at the rear of IAC, so it is safe to sharp scrape the residual tumor posteriorly, then achieve total resection. We use endoscope holder to hold the endoscope during the operation. Then we can fairly use our microsurgical instrument with two hands. How to balance the degree of tumor resection with post-operative facial and cochlear nerves function is a dilemma faced by the chief surgeon. Patient is the best scale. For large acoustic neuromas, near total resection of tumor or even subtotal resection is enough. But for small and middle-sized acoustic neuroma, we should strive to achieve gross total resection of tumor under microscope or even endoscope, while preserving the facial and cochlear nerve functions. The degree of resection for acoustic neuroma is divided into three situations. Thin layer enhanced MRI of the IAC confirmed total resection. 2. Total resection under microscope. 3. Total resection under endoscope. We consider subcapsular resection of acoustic neuroma is total resection. This picture shows the functions of IAC under the digital variable view endoscope at 90 degrees. We can see during the operation, both the facial and cochlear nerve were preserved. The direct visual angle of microscope intraoperative neurophysiological monitor is very important. At the end of surgery, with the stimulation of 0.1 milliampere, the facial nerve induced electron myography showed good result. In cases which hearing preservation is possible, it is necessary to avoid damage hearing structure within the petrous bone. We must carefully evaluate the safe grinding ridge of the posterior wall of IAC. The direct visual angle of microscope and the axle of the IAC is different. There is an angle about 90 degrees. So with the 13-degree endoscope, we can't see the fundus of the IAC. The actual required angle of endoscope is 90 degrees. Compare with pre-operation MRT2 image 1 week after surgery. MRT2 image shows the tumor has been resected totally. 1 week after surgery, enhanced MRI image shows the tumor has been resected totally. 1 week after surgery, enhanced MRI thin layer image shows the tumor has been resected totally. Pathological diagnosis is schwannoma. 50 days after surgery, HB of facial nerve function was grade 1. 2 months after the surgery, facial nerve dynamic function was HB grade 1. After communication with the patient agreed to use his photo, audio, video, and medical recorder for case report. We sincerely thank the patient for his support and contribution to the development of medical science. 11 months after surgery, hearing test is class B. For those patients who have preserved serviceable hearing after surgery, should have long-term follow-up of their hearing test. 11 months after surgery, MRT2 image shows the facial and cochlear nerves in IAC. Here, enhanced MRI image show tumor has been totally resected. Case 2, left acoustic neuroma, cause 3. The patient suffering from left ear tinnitus with hearing loss for 8 months, headache and nausea for 1 month. Physical examination suggests hearing loss in left ear. Preoperative hearing test is class D. Preoperative MRT2 image show a left acoustic neuroma, cause 3, with little CSF signal at the natural edge of the tumors inside the IAC. Enhanced MRI image show the tumor extend significantly in IAC and the enlargement of IAC. CT bone window images show significant enlargement of the left IAC. CTV show there is a left high jugular bone. We plan to resect the tumor totally under the variable view endoscope and do not draw open the posterior wall of IAC. Near total resection was achieved by the combination of 3D exoscope and variable view endoscope via sigmoid approach. 3D exoscope provides comfortable position of the surgeon during the operation. At the same time, high definition 3D images improve the quality, depth of the field, and the color of images. After remove the tumor in CPA, use subcapsular separation. We scrape the tumor inside the IAC. Use our 3-piece set of IAC dissector under 3D exoscope. It's safe and effective. It's very easy because the number 3 dissector is a scraper. It has a blade upward. And then under the rigid variable view endoscope, take 90-degree angles. Adjust the angle from 15 to 90 degrees. We can see the residual tumor here. We scrape and remove the residual tumor at the bottom of the IAC step by step. use our three-piece set of IAC detector. Again, patient is the best scale. Scrap off the tumor step by step. It's safe and effective again. At the end of surgery, with a stimulation of 0.05 milliampere, the facial nerve-induced electromyography showed good results. Here is the left high jugular bone. Surgeon cannot see the fundus of the IAC. At the bottom of the IAC, only use a 30-degree endoscope without opening the posterior wall of IAC. Pathological diagnosis is Neuroma because the patient's pre-operative hearing test was class D, so there is no improvement after operation. Compare with the preoperative images. Enhanced MRI scan show near total resection of the tumor 3 days after surgery. 3 months after surgery, facial nerve dynamic function was HB grade 1. After communication, the patient and his family agreed us to use hair audio, video, and medical recorders for case report. We sincerely thank our patients for their support and contribution to the advancement of medical science. 3 months after the surgery, MRT2 image shows the tumor has been completely resected. 3 months after surgery, enhanced MRI thin layer shows the tumor has been completely resected. Summary: proper management of the internal auditory canal is very important for the preservation of the facial and cochlear nerves, and the gross total resection of acoustic neuroma. Individualized preoperative evaluation should be implemented to achieve individualized management of acoustic neuroma. The microscope, reached variable view endoscope, even 3D exoscope can complement each other for acoustic neuroma surgery. The reached variable view endoscope enrich the connection of microscope endoscopic combined surgery. The 3-piece set of IAC detector has launched this year. Thank you for your attention.
Thank you very much, Professor Dong. It's a beautiful presentation on how adding tools for visualization can be very beneficial for us, helpful during surgery, and also helpful for the patient. So in the beginning, I would like to invite all the panelists and also the participant, if anyone has any question, can raise their hands. I have not yet seen any question at Q&A. Ben is raising his hand. Okay, Ben, do you have anything to ask or add?
Yes, thank you, Professor Dong. And it's a very beautiful operation. And I also use endoscope or sometimes exoscope in open surgery as well in posterior fossa. So I would like to ask about some of your tips in doing this. First of all, I would like to ask about during your operation, how do you compare the using the robotic arm robotic arm for the endoscopic holder versus your assistant holding. So in my experience, I find that it will be very steady for using the endoscopic holder. So, but how about in your experience? So, do you use a country-made robotic arm for the endoscopic holder during your surgery? Because I as far as I know, maybe it's hard to import Japanese Mitaka pneumatic robotic endoscopic holder to China, as far as I know. So I would like to ask about your experience using the endoscopic holder. And my second question is during the surgery for acoustic neuroma, when you manipulate the IM, sometimes the BAEP will drop, and during your dissection of the tiny tumor from the cochlear. So how would you manage that? Would you stop the operation as soon as the BAEP drop, and or how would you manage to achieve the gross total excision in the IAM part? Thank you, Professor Dong.
Thank you for your question. Firstly, at most of the operation time, I will use the endoscope holder. Just at that time, I just need watching the area of operation. I use my hand hold the endoscope. When I operate with two hands, I usually use the robotic arm. It's very useful. Can free our two hands to operate. Yes, it's very useful. That's my opinion. And
the Chinese brand of the holder?
And that's made in Germany.
Oh, I see. So,
in our department, our endoscope holder is made in Germany. Yes.
I see. Do you use the same endoscopic holder for your exoscope? Because sometimes
Yes.
I see.
The same endoscope. Yeah. Yes. I have just now I have shown the picture in my PPT. When we training in laboratory, when we use endoscope or exoscope, we use the robotic arm. Yes.
I see. Thank you. So for the second question,
Well, the second question you are say in the operation the BAEP monitor. Yes.
Yeah.
But in my opinion, at recently, in the operation, I didn't found the BAEP have a very strong change because at this moment, at this time, we use the subcapsular director. Yeah. But maybe years ago, in the operation, I found the BAEP changes and have to stop the operation. But this time, at this moment, I didn't have this change.
I see. Can I ask one last question? It's about about the acoustic neural surgery, because sometimes I know that the subcapsular dissection is very good to preserve the nerve function, but sometimes the tumor is quite vascular. So after if you just use the curette to debulk it, so sometimes there will be some venous oozing from the capsule. So there's also one of the daily problem that we encounter. So how would you achieve the hemostasis when you do the subcapsular dissection with the curette? So in my training, I was taught we need to avoid using the bipolar and to achieve the
Yes.
heat. Yes. How would you do the hemostasis?
Yes. Bipolar can damage the capsule. So sometimes the capsule of the tumor is not intact. So if I found the capsule is not intact at somewhere, I will move to another point to find the capsule. Yes, yeah. Move one point to another point. Maybe after the operation, you move to the point just now you found the capsule is not intact. At this moment, the capsule can be seen by the surgeon. Yes.
I see. But how would you stop the bleeding? What technique do you use to stop the bleeding from the tumor?
And we have the neuro physiological bleeding
就是它的
suture cell to put suture cell on the bleeding point. Not use bipolar at the first time. Just put the suture cell on the bleeding point. Maybe can work. Maybe can work.
I see. Thank you. Thank you so much.
Thank you, Ben. Because usually I think the bleeding comes from the oozing instead of like an active bleeding. So I would suggest, I agree with Professor, by just using Surgicel or just irrigation, and of course be patient about it because it will stop if it's oozing and it's not an active bleeding. Okay, I think Professor Tapa has a question.
Yeah, thank you once again, Dr. Zong, for a very wonderful demonstration of your technique and the devices which you have been patented, and you're discussing about those 3-set dissector set. You have rightly pointed out a few of the nitty-gritties of the procedure as to the arachnoid dissection. Then you were very careful use of drills. And then you have actually also mentioned about the use of microscope and how the exoscope has now come into picture, and the robotic arm. In my place also we are using the Mitaka Pneumatica. Now it is no longer available in the market, but then it is very handy to hold the endoscope. And as you have, since we're using Kino 900, we did explore Kivo also, which is an inbuilt endoscope. But since it is not as variable as the Indo-Chameleon, the endoscope which you are talking about in this presentation, which goes off from 15 to 90 degree, it's definitely a plus point with the Indo-Chameleon endoscope. My question to you is, you have very beautifully shown in your laboratory models how you are training these students, because this is very important. Handling an endoscope at 90 degree visualization and then using a dissector in a very small cavity is very difficult to move around. So can you just tell us some tricks as to how you are doing it, different orientations of using a 90 degree scope with dissectors? And secondly, I would be interested to know why you are still stuck with this with the park bench position when most of the people are now doing the sitting position, which we found is very good in controlling the hemostasis, and most of the tumors which are going up actually falls down. So these two queries. Thank you once again.
Under the digital variable view endoscope, the operation is difficult, yes, but in the operation in the IAC is simple. It just need us use the scraper to scrape the residual tumor towards the backwards the posterior wall. If you use digital variable view endoscope to do other operation, maybe very difficult because the structure relationship is changed. But in the IAC, it's the operation is very simple. Just scrape the tumor towards the posterior wall. That's my opinion. But for the neurosurgeon, training is very important. So the young neurosurgeon must come to the laboratory to training how to use microscope, use endoscope, and maybe even the 3D exoscope. Training is very important for neurosurgeon. Maybe for older neurosurgeon. Yes, that's my opinion. Thank you very much.
And regarding the position of the patient, the park bench, do you feel that using these instruments is far more easy in park bench position as compared to the sitting position?
Yes, we always use the park bench position. I think it's very useful or it's enough for the acoustic Neuroma surgery.
Because my experience when the sitting position using an endoscope inside these area is very good because the chances of fogging is far lesser, and since the tissue starts falling away, the endoscope is not touching the tissues when you are entering the endoscope inside those cavities. So sitting position actually gives a little bit more benefit as compared to the park bench. But then you are an expert and you have been doing a marvelous job, and congratulations on an excellent results.
Yes, semi-sitting position is very good for acoustic Neuroma surgery, but I have no experience about this semi-sitting position. Thank you.
Thank you. This is a wonderful discussion. If there's no more question from the participant, I would like to ask Professor. I think this is very interesting. Then yet you introduce the variable endoscope, which I know that there are the group in Rome. They are using the flexible endoscope to visualization in the IAC. I have no experience myself regarding the flexible endoscope, but I would like to ask, why would you think the variable endoscope is an adjunct compared to the flexible endoscope compared to the rigid endoscope?
Maybe
the variable endoscope versus the flexible endoscope, Professor.
And the soft flexible endoscope, the surgeon must use two hands to work on the endoscope. But the rigid variable view endoscope, we can use the endoscope holder, then free our two hands to do the surgery. So I know the company will combination the rigid variable view and the soft flexible endoscope but in the future, I think they will more useful, flexible endoscope.
Okay, thank you. And could you describe more details on when will you choose this the degree of the scope? Because I understand that you change it in the where the holders are, right? So that you need to take out your hands first from the operating area and then change it and then go again. I don't know. Do you have any working with the ENT or with someone that's actually also like a team so that you can help one another on how to visualization and also performing surgery without having to go in and go out of the operation area? When to change the degree of the scope?
I have a lot of ENT surgeon friend, a lot of friend, but I do the acoustic neuroma just by my own team. I can my team can do the all kinds of the acoustic neuroma. I can do the all kinds the three topical approach to deal with the acoustic neuroma because I have training in the ENT department. Yes.
So in the
That's it.
beginning, when you introduce, you will use the 15 degrees. Am I correct? Like when you insert the scope, first you use the 15. And then when will you choose to 90 or do you change? I mean, after the really
at the first, you put the endoscope into the surgical area. We must use the 15 degree because then step by step to change the angle to 19 degree. We can see the fundus of the IAC.
And how about the how far is it from the IAC? Because as we know, long-term use of the endoscope will also increase the heat in the area. I don't know if you ever have that experience on the heat of the endoscope because it was being placed too close to the nerves, so that it can also make maybe a transient post-operative decline of the nerves function. The heat from the endoscope. So how far do you usually put it? How far? How centimeters or?
Maybe I understand your question. I put the end, the front end of the endoscope, maybe 1 or 2 millimeter near the area of the operation, because the area operation we put the cotton, a piece of cotton, cotton plate to protect the the brain tissue or nerve.
Okay, thank you. And maybe my one last question would be for the intracanalicular lesion. Do you always use the CPA approach, like retrosigmoid approach? How about the middle fossa approach? Do you have any comment on that? And maybe you can also have a comment a little bit about the experience on using it in the middle fossa approach to also go to the IAC with this variable endoscope.
Thank you. Just now, I have said I can do 3 typical approach to the acoustic neuroma. So I do the middle fossa approach to resect the little smaller acoustic Neuroma. It must be smaller than 1 millimeter and must inside the ISA. Inside the ISA. That's my experience. Thank you.
Do you also use the variable endoscope in the middle fossa approach?
No. I have no experience about the use the endoscope in the middle fossa approach. I didn't have experience.
Okay, thank you very much, Professor. Is there any more question from our panelists or our participants? I was really happy when Raja and Ben give me the topics because it's very interesting. Yes, please, Professor Tapa.
Yeah, the question which you raised about the heat generated by the endoscope is very relevant one. In fact, there have been many clinical studies, both presented by otologists also, who have been working inside the middle ear cavity through an endoscope. And they found that usual endoscope, which we are using at the intensity is 30% xenon light, it hardly presents a temperature of 31 degrees centigrade. So that's not too high. However, if you are going a luminosity to 100%, then the temperature may rise to as high as 110 degree. This is for 40 millimeter endoscope, which the variable endoscope is the usual diameter. So that's why the 30% luminosity has been considered to be like a safe zone for working with an endoscope inside a CP angle or middle ear cavity.
Thank you for the info. So do you also use the 30%, right, Professor Dong? For the light, do you also use the 30%?
Yeah. I didn't think about this question. This is a good question, but I didn't have opinion about this good question. Thank you.
Okay. Thank you, Professor. Okay, I think this is a very wonderful discussion today. I really hope that everyone, all the attendees, and also maybe everyone that will watch this afterward can gain a lot of confidence to start using both microscopic and also endoscopic to combine it to have better visualization for the surgery. Of course, it needs more training. But I think it will be very beneficial for us as surgeon and also for the patient to remove the tumor as much as possible safely. Thank you very much, Ben. I think it's back to you. Are we ready for the second presentation by Johan?
Yes, maybe shall I invite our chair, Professor Amit Thapa to invite our speaker, Professor Johan.
Good evening, everyone. Good evening from Nepal. In fact, this is around 6 p.m. here, and it's my opportunity as well as a privilege to introduce you to this topic. The topic which has been provided to us for this meeting is challenges of developing a neurosurgical unit in a developing country. And this topic is very relevant, particularly for the young neurosurgeons who are recently passed out, because as the number of well-established departments is few in developing countries, the neurosurgeons who pass out, they have to go and develop a unit separately in different places, either be in private or public institutions. And most often, the neurosurgeons who are trained in our part of the world are basically the general surgeons who have now got another additional training to become a neurosurgeon. So how they are treated in whenever they join a new institution is basically as a general surgeon combined a neurosurgeon. And similarly, these challenges come up, and this is not only from the neurosurgeon's point of view, but also there are different problems when one person is starting a neurosurgical unit, both from institution, both from the government side, and even from the community whom he or she is serving. So there are a lot of issues which we think once we discuss about these things, then the surgeons who are getting trained right now, they are better prepared for taking these challenges in the future. So without further ado, let me invite Professor Johan Chok for his talk on challenges of developing a neurosurgical unit in a developing country. And after his talk is over, we will have a discussion about this particular topic, both with the panelists as well as with the audiences. I will request all the audiences to keep writing their comments or any queries related to his talk in the chat box, and we can take it one by one after the talk by Professor Johan is over. So Professor Johan is from Peru, and may I invite Professor Johan to share his screen for the talk.
Okay, thank you very much. Yes, I will give you, thank you for this nice invitation by your committee. So I am just here in my country very few years ago. I am 2 years ago here. I returned from Finland. I was with Professor Hernesniemi there. And yes, I would like to share with you some of my thoughts about the challenges that I faced here for opening, or not for opening, but for continuing one neurosurgical unit here in my home city, Cusco, in Peru. So some introduction about me. I am working here in the Regional Hospital of Cusco, Peru since June 2022. We have around 20 beds in the general yard with some intensive care unit beds, and we are playing here like 6 neurosurgeons with all the staff of nurses and all the staff of a general hospital. This is like a not so a high demand hospital. We will see soon how the population. So I am also working as a docent in the university here in Cusco. And some things about that timeline here in Cusco is that when I arrived here, we didn't have any microscope. So we tried to adapt an ophthalmological microscope for our operations in 2023. And luckily, we got a last generation operative neurosurgical microscope this year in May 2024. So with that, we are very happy, and we could do bigger things. Also, we got some portable fluoroscope in this year. So now we are doing angiographies, and also we are trying to make embolizations, and we are trying to manage some vascular cases. But still, we don't have since our operative microscope is recent. Then still, we should bring our micro instruments and all our staffs, like the neuroscientists, we should bring to the hospital that. And still, we don't have exclusive intensive care beds for the operative care, so we should fight a little bit with other specialties for our patients. And also, we don't have an exclusive operative room for neurosurgery. So we are trying to look for these 2 aspects for changing in the hospital. Next, please. Yeah, this is my gratitude to Professor Hernesniemi. I was trained by him in Finland. I visited China. I went with him to many places. So some background about this developing unit neurosurgery is that in 2016, we came with Professor Hernesniemi to Peru to make some kind of similar project in another city in Peru, in Trujillo. So we performed a lot of neurosurgeries, complex neurosurgeries during 4 to 5 months in Trujillo. So I got the experience how to manage these challenges. Thanks to him, he was very appreciated here in Peru and surely all around the world. So I give my thankful words to Professor Hernesniemi. He passed away last year. So we are happy. I was happy to be with him. So for that, we made this publication, how to develop a high specialized neurosurgical center here. And we closed that training course with cerebral bypass live course. It was in 2016. We invited some professors of Japan. We had another professor here in Peru, and of course, Professor Hernesniemi. And thanks to that, we created that neurosurgical center in that city, which has Professor Hernesniemi's name. So it's Juha Hernesniemi's neurosurgical center. Next, please. I was trained there in Finland. So thanks to that, I have 2 books. We published the 1001 videos of neurosurgery with Professor Hernesniemi, and also I published my doctoral thesis based on pineal cyst and tumors. And actually, I studied a lot of the pineal region cases of Professor Hernesniemi. So we collected a lot of videos, and we got a lot of information for that. So those are very open access books in the internet. Next. Yeah, this is Peru. This is my country in South America. Population for this year around 33 million people. And inside, in the south part of Peru is Cusco, my home city, which has around 1.5 million for this year people, you know. And we have here just 2 neurosurgical centers. We have 2 different systems in Peru. One is the working insurance hospitals, and another is the public insurance hospital. So I am working in this public hospital, which covers most of the population. Yeah. Next, please. Yeah, this is the hospital here in my home city. It was founded 60 years ago. It didn't change until now. You know, we have a lot of issues here in Peru, basically based on maybe on corruption. So there is no money coming to the hospitals, but probably the money is going to other pockets. So, but still, I think we have a good quality of personnel, nurses, good staff, and we are trying to go forward against those difficulties. Next. So what I faced when I arrived here in the, I classified these stages like in three different stages, like the preoperative care, like the intraoperative care, and postoperative care. So in the preoperative care, next, we could face that there is a lot of lack of statistics. So we didn't know here which kind of diseases are most frequent. For sure, brain trauma, it was so frequent, spine trauma a lot, but there were not cases there were not vascular cases operated here. So there were not statistics about the AVMs, about the aneurysms, about the cavernous malformations. There were not statistics about complex surgeries like vestibular schwannomas or hypophysis tumors or pituitary tumors. So people here or all the hospital were thinking that we didn't have these diseases, you know. And but most probably the patients were transferred to the capital, to the center, to the capital of the country. And here we didn't have that information. So we had to make some kind of demand analysis. And based on that, we had to create a budget for this year. So, because of course, to operate complex cases, you need a lot of logistics, and you need to buy or at least or rent some services. And here, that is the question that usually the hospital doesn't buy things, doesn't purchase materials, but rent services. There are a lot of private companies that offer, for example, craniotomes, or offer ultrasound aspirators, offer any kind of devices, micro instruments, what else? Clips, you know. So the hospital by itself doesn't have all these materials. So for each case, we should ask some buy-ins. And we have luckily this universal health system here that can buy even for the poor patients, for the poorest patients, all the services that they can require. If patients might need, we had some cases for radiosurgery, so even those cases can be afforded by the hospital. You know, the patient doesn't need to pay anything, and that is a good thing for the patient. So in the preoperative case, we had to check all this stuff, and now we have some more idea about which kind of diseases we are facing. Next, please. In the case of the intraoperative care, next. We could face very challenging situations. First of all, our anesthesia team, since they were not used to face some challenging cases where there was at the beginning a lot of resistance for operating ruptured aneurysms, for operating AVMs, for operating posterior fossa tumors. First of all, because they were not used to some special positions where we are doing in neurosurgery. For example, I think for the anesthesia team is very, very complex to make a sitting position. Yeah, they have a lot of fears for the air embolism or all this stuff, and they don't want to do this. So we here, for example, we don't use this position, even though I know how to place the patient, but there is a lot of resistance for this anesthesia team. So generally we put, even for the park bench position, the anesthesia is very resistant. So we use 3/4 prone for the retrosigmoid approach, or we use Concord position for the posterior fossa. So we try to make it simple positions in these cases. Another challenge I could face is that obviously we didn't have a microsurgical instrument, so we had to bring our instruments. We didn't have also a head frame, and we didn't have a craniotomy drill. So we were taping the heads of the patients to the operating table in some determined positions, and we could work with that. Luckily, the patients didn't wake, and in the case of the craniotomy, we were using like very, very old instruments. I will show in the next slide. So it was very challenging in that way, and we could spend some time making even the approach, only the approach for operating the cases, no? And of course, we couldn't operate so skull-based cases, for example, because we didn't have the operating microscope. So when we got our ophthalmological microscope, at 2 days after we got it, then the light disappeared. So we had to use some room lights for the operating. So it was quite challenging in that way. So the next, please. Yeah. So this was our first microscope, and it was a very old microscope that I found in the deposit of the hospital. It was not working apparently because of the light, but we make some arrangements and we could organize it. And yeah, these were our devices for the craniotomy, very prehistorical devices here even in Peru. But we started working with this. And yeah, we had to do this because we had a lot of emergencies and we had to solve the case. Next, please. So what makes me bring, what made me, or how it made me solve the situation in the operative room, because it was very challenging, as I told you, with the anesthesia team. So many cases were going to be stopped before operation, and we have to show that the neurosurgery is a simple procedure. That is what we had to show to the anesthesia team. So we had to make simple positionings for all the patients. We had to make minimal intraoperative bleeding. So because even for that, the anesthesia was very, very strict. And also we had to make reduced operative time, because since the operative room was shared by other specialties, well, also we had another emergencies, and we had to make it simple and fast, as Professor Herensdemir said. Next, please. And well, once we did that work, once we operated those patients, the post-operative care also was challenging. Next. And basically because the intensive care unit personnel didn't have the experience for managing some special cases. Of course, they had the enough experience on the optimal experience for the traumatic brain injury, for some brain tumor surgery, especially the extraaxial or even some gliomas, some cortical gliomas, they were managing well. And also even for the aneurysmal subarachnoid hemorrhage. So those cases were somehow well managed. But we had a lot of trouble with some special cases, for example, the pituitary surgery, because we got here large cases, very, very, very big tumors, and they had to go to intensive care. So the personnel there couldn't manage well the endocrinological aspect of the pituitary surgery, especially the use of desmopressin or vasopressin after the few hours after surgery. So for the for the diabetes insipidus. We had a lot of trouble in this situation, so we had to train the personnel for making it well treated. The patients had to be well treated. So we have some challenges, especially in this pituitary surgery for the endocrinological management. And another problem what we faced, it was in the arteriovenous malformation surgery, especially in the large cases. They couldn't manage very well, or they couldn't understand very well the importance to manage it with reduced blood pressure postoperatively. So many patients, they were awakening, or they were like having a high blood pressure, and we had some a couple of cases with intraoperative postoperative hemorrhage. So luckily we could solve the situation, but also that we had to train in the way that the patient could recover fastly. And I think now those two cases are, or those two situations are better managed. Okay, next. However, as in any institution, the essential caregiver for all the patients, neurosurgical patients, are the neurosurgeons. So next, please. So also we had to make our team to be like a qualified team, because for a neurosurgery, I think the most important aspect is to have a qualified neurosurgeon. We might have, as I could see here, we might have maybe some modern instruments, some modern microscopes, some modern tools, but if we don't have qualified neurosurgeons, those are useless. And I think these values are very important for a qualified neurosurgeon. We should have a very specialized training in different aspects. We should be honest with our patients and also with our colleagues. We should have somehow good outcomes. If we don't have good outcomes with our cases, maybe we cannot continue. We need to train. Also, we must have a good communication with our patients and also with our team and with all the personnel which is in charge of our patients, and also that will make a great team, not only between neurosurgeons, also with the intensive care doctors, with anesthesia doctors, with all the staff. Patients also need a personalized approach. As I could see, I will show you some cases. For example, there are some cases that could be approached by some endoscopic approach in some pituitary cases, but the other cases, of course, we had to make a craniotomy, and we had to do some microsurgical resections. And one important thing, especially here with some poor people, is the empathy. We have people that doesn't speak Spanish. Obviously, Spanish is like the official language in Peru, but also we have indigenous people who can speak Quechua, and they feel lost when they come to our hospitals, and nobody else can be with them. So I think those are very essential aspects for our patients. So next, please. I will show you here then some of our cases. I consider some challenging cases. Maybe they are not so complex for you, but well, I consider them some challenging cases because we could have some difficulties and also some nice results in these cases. We have this spinal meningioma. This patient came with paraplegia because it has a very compressed spinal cord by this meningioma. And after 2 months, she recovered and she was walking. So we did a microsurgical resection of this tumor. Next, please. Also, we could make some anterior cervical spine surgery for this patient who had a traumatic spine surgery, a traumatic spine fracture, and we could replace and we could make the corpectomies, and we could make all the instrumentations in those patients. And those are all of them. We had good results with these patients. Here still we don't have our neuromonitoring, intraoperative neuromonitoring, so we have to be very careful with the microscope and go very well, nicely with our approaches. Next. Also, we could manage some scoliosis. This was a 2-year-old kid with some scoliosis due to the hemivertebra, so we could make a hemivertebrectomy and we could make a posterior fusion of the spine. Next. Also, we had more complex cases with multiple hemivertebra, and we did bigger fusion of the spine. Luckily, in some of these, we could arrange some neuromonitoring. Yeah, there are, as I told you, there are private companies that can offer those services, and yeah, when it's really required, we ask for them. Next, please. We performed this anterior spinal approaches. Yeah, we could put this interbody. We could make this interbody fusion and put some artificial disc on these cases anteriorly. So patients with this kind of vertebral claudication and this kind of diseases were treated here. Usually they recover very well. The correction is made very nicely, you know, and the interbody space is also recovered. So this patient had a lot of difficulties for walking, and later she was quite well, and she went home, and she's still quite nicely doing right now. We also performed some posterior approaches for these interbody fusions, and yeah, we could have very nice cases. Of course, we had traumatic spine cases, which are approached as usual, but I am showing you these special cases, you know. We could perform also these endoscopic pituitary surgeries. For these cases, those were nicely approached. I invited a colleague that could help us with these cases, and yeah, we did it. Our colleague also came with his instruments, and of course, we did nicely this surgery. With all the benefits of this endoscopic surgery, the patient was going out maybe next day, and he didn't have a lot of endocrinological issues, and also no cerebrospinal fluid leak. So those cases also were very nicely done. Next, please. We could have these large cases also. It was a vestibular schwannoma, which was completely resected through the microscope. For this case, we had to put the patient in the three-quarter position and move the head so that we could approach by the retrosigmoid approach without difficulties. You were talking about some bleeding in these cases. Yes, I also faced some kind of bleeding in this case, but I tried to make some solution. So I put some peroxide water in a reduced percentage. So I just injected when I was approaching inside the tumor, and then I could go with the ultrasound aspirator until some level, and the patient preserved his all the nerves in the posterior fossa. In the beginning, he had some kind of dizziness and balance issues, but and also some kind of weaknesses in the facial nerve. But he recovered after 1 month and a half. We did some kind of recovery of the facial nerve and some physical therapy, and the patient is doing well. So this was a very challenging case for us, but we faced it very well. We had also some another small size tumors, and they were also approached very nicely. Our goal is always to preserve, even in these large cases, our goal is always to preserve, of course, the cranial nerves, and also to avoid the bleeding. Yeah, but curiously here, as I told you, yeah, we couldn't use the sitting position or the parking position, but we had to organize our positioning so that the anesthesia team could let us to work these patients. Next, please. We had also these large cases, of pituitary surgery. So we couldn't approach these cases with endoscope. Of course, it can be done, but maybe our experience was not enough for doing this surgery. And we went through the lateral supraorbital approach, and we approached this first. We cut the head of the tumor, as I said. So we tried to coagulate all the capsule and cut and go until the prepontine cistern. And when I cut all the membrane of the tumor, so the tumor was devascularized, and the internal decompression of the tumor was quite easy. I could use some ring forceps to debulk all the internal tumor. And later, when it was empty, I could also take the membrane. So I could see that since the vascularization of the tumor is cut in the neck or in the basis, in the around the cellular region, so there is very little risk of regrowing and very little risk of recurrent tumor. So we try to make our approaches in that way, and also we try to use some instruments for taking out the tumor inside the cellular region. And but as I told you, after this, most of the patients developed a transitory diabetes insipidus, and this was the challenge for the intensive care unit people until they learned how to make a correct diagnosis of the diabetes insipidus, because some little bit older patients, they had some losing syndrome of salt, and they were confusing with this diabetes insipidus, so they couldn't recognize very well when to deliver desmopressin to the patient. So it was the challenge, the endocrinological challenge for the intensive care unit. Luckily now we are managing quite well our cases, and that time in the intensive care unit also is reduced, and these patients are going well. Next, please. Yeah, we faced these cases. We had a huge malformation in this patient in the left side, in the eloquent area. We were planning, maybe to make some kind of endovascular approach, but the issue in this patient was the recurrent seizures. So the patient was presenting with recurrent seizures, most of the time having like a status epileptic, and they were very resistant to all the drugs what we delivered, so they had to go to intensive care for sleeping, and we had to operate this patient. We had to open to make the craniotomy and to operate this patient. The immediate operative course was, of course, with weaknesses and with aphasia. But as we could see how the AVM malformation patients develop, or how they go after surgery, usually the patients, they improve the motor function, and they improve also the language. So this patient was improved her aphasia after 2 months and a half, and also she improved the hemiparesis after the same time. Still, the weaknesses on the hand and on the fingers is the most difficult part of after this surgery. So she was still training that motoric area. But I think it was the unique way how we could help these patients, since the endovascular treatment also doesn't reduce these critical seizures of the patient. So after this, the patient didn't present any more seizures. So the seizures were because of the high flow of this malformation. Next case. We have this another challenging case, this large arteriovenous malformation, luckily in the occipital area. So, but with big, deep feeding arteries and large venous drainages. And in this patient, for example, we operated. The immediate postoperative care was good. But after the next day, the patient had bleeding because the blood pressure was not well controlled and the patient was awakening. So the intensive care people, they saw that the postoperative CT was okay, that the patient was okay. So they decided to wake this patient. And of course, the quick awakening of the patient made her to bleed. She developed acute subdural hematoma that we had to enter, and this acute subdural hematoma also made a large brain swelling. So we had to make a decompression, a craniotomy and decompression. Luckily, the patient went well. Now she recovered. She's quite well. Well, we are seeing how she's developing, but malformation was totally resected. Next, please. We have some of these aneurysm cases in different positions. We have ACM aneurysms, paraclinoid aneurysms, anterior communicating aneurysms. And also this first case, it was like a clinoid aneurysm, carotid aneurysm, like a blister case, which was very challenging. We had to use this, we were trying to use this double clip technique for closing this because it was very challenging even to clip the aneurysm. But thanks to this modern microscope, well, we could did well these cases. So those are the surgical cases. And also, next, please. We have part of the neurosurgery is, of course, to use these modern tools. We performed also a radiosurgery for a residual tumor. Patient didn't want to experience it. He was operated in another center and he experienced a bad postoperative care recovery. And he didn't want to go anymore to a new surgery. So there was a residual tumor that we treated with radiosurgery with a barrier machine. And yeah, this patient also could get the benefit of the social insurance, and he didn't need to pay this. And next, please. Also, yeah, thanks to this our new fluoroscope, we are trying to make these panangiographies, angiographies, and we are trying to make embolization of the cases as a part of the developing of this our neurosurgical unit. So I show it to you some of my cases. For sure, there will be, and there are still some other cases, but I wanted to emphasize, yeah, these 2 years. I think I lost some part of my life for working with these challenges, but I'm happy to be here, and I am happy to make what I really love. So this is all my presentation. Thank you. If you have some questions, please.
Lovely, Dr. Johan. That was too much of work for a 2-year period, I should admit. And congratulations on having established a good unit. And you are doing marvelous job with a lot of limitations around you. You have been able to push through your objectives. And well, this is the story of almost all the neurosurgeons who get trained. Because after long years of training, once you come into the practice, you start looking for an area to work. And most of the surgeons actually do a mistake, which you in your presentation have very rightly enumerated, that the 4-point approach. One should always be having a statistics. So one should always have a ground reality of what is being demanded for. Because when as a surgeon we join a job, we think that we are good to do everything. And then suddenly we find that is not required in that place. And that's how we get lost. So getting in the statistics and then looking for what is being demanded for on the ground, and then looking for the budget, and of course, return on investment on what all has been invested in your devices is a very good method. And you also talked about the different approaches you had for the intra-op care of the patient and also in the intensive care. What I also like to add to this list is how you deal with your emergency physicians, and the pre-hospital care is of utmost importance, because neurotrauma is something which establishes a surgeon or neurosurgeon in its working place and in the beginning. And once we start having a good care of the neurotrauma patients, then only we start getting trust of the patients, where we can develop on the skull base and neurovascular and endovascular, and further going to radiotherapies. That is one thing which we all should be careful about. And regarding this talk, which you talked about as a community doctor, of course, I would like to bring into highlight the publication by Charles Bolin. This, I think, was published in 1994, where he was addressing the general physicians as the frontline doctors of tomorrow, and he called them that one should be a 5-star doctor. But I believe that every neurosurgeon who goes on to establish a unit in the peripheral hospital or any other hospital has definitely have to go through the 5 roles, which he has enumerated as a criteria for a 5-star doctor. Not only he is or he or she is a caregiver, but also decision maker, a communicator, which you have rightly put up in your slide, but also is a community leader and the manager. And this managerial role is very, very important, because unless until you do not manage your team, you don't manage the place in which you're working, the results are not going to be that superior. And of course, this is very important. So I would like to know from you, like you definitely have a lot of challenges in your place, and particularly you have mentioned about the anesthesia team, where they were reluctant in giving you certain different positions of the patients. So how do you actually tackle in these scenarios? Because this is very important for the surgeons who are trying to set up a practice to understand and to take how to make a rapport with the allied specialties, particularly when you are embarking on a very complex case, you are alone, and you do not have a very steady help coming through.
Yeah, I think it's very, very important to face the reality, as you told. So we should analyze the case. And first, with the neurosurgical team, we analyze the case and we say if we can manage the case or not. Of course, we enter to the operative room still with 2 neurosurgeons, the main neurosurgeon and the assistant and the helper. And the next, I think, for me, at least, when I see in a retrospective view, I think it was very important what I saw from Juha Hernisniemi in Finland, and with his goal, simple, fast. And in that way, I think we try to simplify the approach. We try to make it easier for everybody. Of course, looking also all the limitations and all the facilities that the approach can be made. But I think, for example, if I could perform a patient in a sitting position for this vestibular schwannoma, I am sure that the patient would have some complications. In the maybe not surgical complications, but I am sure that we could have some challenges for the intraoperative management in the anesthesia team. So I could see, for example, there you have most of the patients he was operating in a park bench or 3/4 prone or prone, and sitting position was mainly used for posterior fossa, but also, revising the literature, I think there are suitable positions for centers with these challenging cases. No, James Hausman proposed this 3/4 prone, or there are others who propose the Concord. So we analyze the case. We try to see if we can manage this with our tools, with our team, and then we just go forward. I think that is the way how we try to make it. And also in the beginning, of course, if we had some challenges, especially when we had the not
It seems Dr. Juham is having some problem with his audio.
Developed a microscope. Okay. Can you listen now? Hello?
Yeah. Now you're audible.
Okay. Yeah. So, as I was telling, is that for sure it was also a process. It was a process. So, in the beginning, when we faced some challenging cases, some skull-based tumors, skull-based meningiomas, and maybe we could go only until to resect radically. We couldn't make a complete resection. because of the safety of the patient, because of our also safety, and also because of the not to make it the case more difficult that was, and but step by step it was also a process of developing, and I think the anesthesia team and the intensive care unit team, they start to trust more in us, and I think that was very important, because if they don't trust, then they don't give you the operating room, or they don't give you the postoperative bed. So first we had to create the trust within all the team, and we had to be realistic and to tell them what we could do and what we did.
True, very true. Well, what I have realized in my practice also is that beside the trust which we want to generate amongst us, it is also very important to understand our capabilities and the limitation. And somewhere what we have realized is that sometimes the allied specialties like anesthesiologist or the ICU team, they may not be prepared enough to take up this challenge. So rather than like finding out the limitations of one another, what we rather like to do is to have a combined discussion on the subject. And the best way is to ask one of your juniors to present a case, or you can yourself present a case and discuss about the various things which the other team would like to be more knowledgeable about, or if they want certain discussion with the expert where you are trained. So that is another thing which we have done in past. So what we had done was like we had got a direct communication between the team with whom I was trained earlier. So that's how also the anesthetic team and the ICU team can become much more conversant with the idea of what we are applying to do. So that actually builds up the trust. I see the hand,
Yes.
Ben. Yeah, Ben, you want to say something? Yeah, please go ahead.
Yes, and thank you, Professor Johannes. And you clearly illustrate that the challenges that face in a developing countries. I have some question that's not mentioned, some aspects that I would like to ask about, not mentioned in your presentation. Because just now, Professor Jung talked about the training in the laboratory. So I would like to ask about the training of young neurosurgeon in your country or institute. So how would they be assessed to some laboratory training, and how would they train up to be qualified neurosurgeons? My second question is about the rehabilitation of the patient, because sometimes the patient will have some neurological deficit, for example, hemiplegia, dysplasia, and so how was the rehabilitation or the care how would the patients that cannot be independent of their life be discharged or rehab in your countries? Because sometimes there will be a very difficult situation in developing countries. Yes, thank you.
Yes, thanks for your questions. Yeah. Here the process of training is, I think, as most of the developing countries, we usually get the residency, we finish the residency, and after that we look ourselves for some other more specialized centers. So we go abroad. We have few lab centers here in Peru. You can train also, you can make some cadaveric training. Nowadays we have these videos, surgical videos, neurosurgical videos that are very, 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 very useful, even for already all the neurosurgeons. Yeah, this was the aim to make those video atlas, for example, because me, for example, when I go to operate an aneurysm case or some vascular case, so I go immediately to see some Johan's videos and see some small details that what we could collect in all this stuff, read his articles or read articles of other people. So this is the way, yeah, just 1 hour before the surgery, I'm looking some videos or watching in general some aspects, reading something else for the small details. But yeah, most of the young neurosurgeons, they visit other centers. They visit other centers abroad, and they follow also older experienced neurosurgeons. Here, for example, we have 2 large centers in Lima, and we have good, very, very good neurosurgeons there. So we visit them, we see their hands, we see how they do. And if we can go forward, we go abroad and we prepare there. And when we come back and when we go to the hospital, for the starting point, we usually enter with a older neurosurgeon. And you should start with some simple case. Also, this is the way we start with the small tumors. We get adapted to the microscope. We get adapted to all the environment in the hospital, and step by step we go forward to more complex cases. So yeah, this is the process of training here. And regarding the second aspect, yeah, it's important, especially we have disabled patients after head trauma, after brain trauma. Here still we don't have a good promotion for the healthcare, so we had a lot of car accidents, motorcycle accidents, and patients, they get injured and they get a lot of disabilities. Our culture is still some kind of family culture. Here we have some kind of groupal culture. So still the family can care the patients, still the parents, still the wife or the husband or the kids can care some patients. In the hospital, we have a rehabilitation center. Of course, it has a high demand. Not all the patients can go there. But also we had some private centers for the rehabilitation. And the costs luckily are not still so high, so that people can afford, especially in the beginning of the postoperative care. But yeah, there are patients that are in the wheelchairs that need to be cared, especially for the family. We don't have a social program or a social support for this kind of patients, and this is something that needs to be improved in our community.
Thank you so much. And I think I will echo with your presentation about the difficulty that you face. So in case you need some support, and you could also talk, feel free to write to us and Professor Kato, and we'll be glad to help. Thank you so much.
Thank you, Ben. Well, I have seen Dr. Selfie also raising her hand. Yeah, Selfie, please raise a comment there.
Thank you, Professor Tapa. First of all, congratulations, Johan. So good to see you again, Professor. So it's been a long back way when we met, when our path crossed. So I would like to congratulate you for what you have achieved. And I really think that Juha will be very proud. And I just want to say that I think his wisdom has passed on you. And I'm really happy how these last 2 years you can develop building all this neurosurgery service, especially with all the limitation that you have. My first question, maybe I understand that from your presentation, the hardest part is to make everyone on board on what your visualization on doing the ideal approach in each cases. So do you have like any multidisciplinary team for each, like for vascular cases, and then for pituitary patient, and then for tumor patients, schwannoma patient? I don't know, because in my experience, I know we also have the same limitation, developing country. So once we ask them to be engaged in a team, and they have their own role for even the intensivist, the neurologist, and also the anesthesiologist, then hopefully it will encourage them to be engaged to the patient, and then to make your life a little bit easier. I think that's in my experience, my first question. Second question would be, how is the referral system in the public insurance there? Does the patient can come directly to your hospital, or do they need to go pass through to other hospitals? So that's why sometimes they come very late stages. Thank you.
Okay. Yeah, regarding your first question. Yes. First, the first thing was to have a good team with our colleagues, yeah, because that we are very proud within neurosurgeons. So sometimes we have the challenge even to join neurosurgeons. So it's sometimes very challenging, luckily I have a boss who is very open and who is a nice person, so he could organize somehow this path to go all together, and I think also to get the appreciation as a team, not only as a neurosurgeon, but to get the appreciation of the community of the hospital as a neurosurgical team. So once we were somehow appreciated in the hospital, say we could go forward, and we could face more challenging cases. For some special cases, we had to join with intensive care people, anesthesia people, endocrinology people, and neurologists to discuss some cases. In the beginning, of course, some cases had to be brought to more specialized centers. We also could see our limitations on that moment, and we could say that, hey, maybe it's better to go to other center. Here still we cannot do this. But I think step by step we could go forward, and then we could organize more complex cases. And I think we have a good communication here, and with all the difficulties, as I am saying, that we have as a neurosurgical team, but I think we could organize those cases. And going to your second question, one of the main limitation, or one of the main challenge for the patient was basically this referral system. So when we transferred a couple of patients to other center, they stayed maybe 3 or 4 months before going to be treated. So here it's very difficult to arrive in a more specialized center, since the distance, the geographical aspects, the language, the social and the economical difficulties that the family face in other places, with that make them to very, very, very difficult to travel and to go to other places. There is a high social issue for that, and a high social limitation for this. Even for coming to the hospital, patients sometimes they need to face difficulties because they should come from primary centers. They should be transferred or referred from primary centers to our hospitals. But I think some patients that are really bad, they come directly to the emergency area of the hospital. They are received. We don't have so hierarchized, is it correct to say? Well, we don't have so well differentiated processes for this referral center, since the patient can come here and we can still accept them. Or sometimes we are in the consultatory, and some patient is coming from some far place, and they say, "Hey, I couldn't go to the primary center, but my family or my relative is bad." So we give some type of extra position, or some kind of additional, what's the term? Some kind of additional place for them, and we put them inside the hospital. So there is not so a strict referral system, at least from the communities to this our hospital. But the situation changes when you transfer from a hospital to a more specialized center in the capital, for example, because here in Peru we are 30 million. Of course, it's not so big population, but for few centers, or for the few centers that we have in the capital, this is a very demanding and very challenging also. So some patients, they are not received there, and they need to be treated in decentralized centers. So maybe also that is some point in our favor, some positive situation, what makes us to develop more and more the center, because we must treat our patients in our place.
It's good to hear. And my last question would be, how would you think the global neurosurgery can help you? I don't know. I know that ACNS is very, very helpful, but I don't know, do you think it will be helpful if Professor Amit Tapak can come and visit you every once in a while or so? No, I mean,
for sure.
Because I think this is what happened, especially after the pandemic, where we can get connected easily, and then you can discuss. If I think everyone here will be very happy if we can help in any way that you need. What would you think you need from the global neurosurgery perspective?
yes, I think it's very important to receive the support from different places, and that means to organize courses, to still develop our center, to still grow as a unit, and to involve all the neurosurgeons here. Yeah, I think from the economical part or from the instruments or this technological part, I think still the country can buy those things. Of course, the process is slow, but I think we got this operatic microscope, so it's already a huge thing, and we can get it more. But maybe the main point would be the education, also education of all the staff involved in the neurosurgical procedures, to organize here some conferences, or to make just a webinars, or to organize like this type of meetings. And another thing is also to let us to be known, no? Because nobody would appreciate if our publications can be accepted, if we can receive support for this type of situations, because still for us, even though we publish it a lot when we were in Finland, but for a developing country, it's very difficult to publish, especially now with open access journals and all this stuff. Sometimes you need to put your own money because there is not budget for these things. So I think it's important to let us to be known in the community, and to receive the support in that aspect, in that part, in the academic part.
Okay, thank you very much, Johan. Once again, congratulations. And I think Ben is here.
Thank you.
He can pass this to Professor Kato, and maybe, I don't know, how ICNS can help. Thank you.
Thank you.
Okay, thank you.
Thank you, Selfie. That was a very good comment from your part. And Johan, your work is exemplary. In fact, I was reading your article, which was published in World Neurosurgery, and you did talk about your center, which started in 2016, and here you are presenting your work. Throughout this years, you have been very much persistent with your motivation and commitment, and this actually gets seen in with the way you're working. And hats off to you. And please let us know how we can be of help in your journey. And of course, coming back to the topic, the whole idea of setting up a department or a unit is to institutionalize the individual experiential memory. You have actually accumulated a lot of good things, the skills, the way that you manage with the people, the management. Now that needs to be handed over to the next generation, so that the department can grow, can thrive, and can build upon itself. And the whole amount of labor you have put in your work gets hand over to the next generation, where the good work can actually become much more amplified. So please continue with the good work, and also keep training people around you, so that the whole team becomes more expert in managing complex cases. So I don't see any other questions in the chat box, in the Q&A. And if any of the panelists have any comments to make, please raise your hand, or you can just unmute yourself and can speak. Yeah, so there is nothing. So let me close this second session again. And thank you, Johan, once again. And thank you all the panelists for their very insightful comment. And we had a good discussion here. And just to conclude this session, I would like to put forward one of the publications which was recently published in Neurology India, and it has been like work of eminent neurosurgeons from all over India. And the title says, "Now What Do I Do?" It's a practical challenges faced by young neurosurgeons in their career management. And this was published very recently in 2024 June. I think this is a very good read for all the young neurosurgeons who want to start their practice. And the tips which Johan actually put forward in his talk is very, very vital. It's an experiential thing. So once who goes through this path has to face all these challenges. With this comment, I'd like to close this session. Thank you once again for listening to this.
Thank you.
Thanks to you. Thanks to you.
Professor Fapa. So on behalf of the Educational Committee of ACNS and the President, Professor Yoko Kato, I'd like to thank you, both the speakers today, Professor Johan and also Professor Jung Dong, as well as the chair, Professor Fapa and Professor Selfie, for the time and the support for the ACNS webinars. A special thanks to Professor Xu Bin for podcasting this webinar on the WeChat channel, and special thanks to my co-host Liu for joining me today. And I would like to echo with Dr. Selfie's view on the global neurosurgery. I think I learned so much today from Professor Jung and also Professor Johan about the acoustic neurosurgery and also the challenges faced in the developing countries. And also, I learned so much from our chair today, yourself, and also Professor Fapa. And I think this kind of global connection is important to us to prepare ourselves for the patients. And this is very important for the young neurosurgeon. And also, I would like to thank Professor Pritchard and also Dr. Evelyn for staying with us for this long yet very educational and wonderful lectures. So until we all meet online tomorrow, is a bye-bye from all of us, and thank you so much for joining